Okay. Great. So I'm just going to press start now. And then Shauna and Louise, what you can do then is you can stay on there for the minute you want, but if you want to turn your cameras off and mute while Martin's presenting, and then the minute he's finished, then you can just pop yourself straight back on in case there's any questions. All right. Great.
Great. Thank you.
Yeah, I can see the numbers going up there. Welcome, everybody. So we'll just get started in a couple of minutes. We'll give everybody a second to get online. The numbers are still going up, Martin. So I'll just wait a minute
That's
till we.
that's good. That's good. That's
Yeah,
good.
it's the nice thing about the lunchtime webinar is everybody grabs their lunch and sits and listens. So we'll give everyone a second.
So we don't see people when they come in, do we?
No, we've got
Yeah.
33 people with us right now
Yeah.
who are listening in. So yeah,
Yeah.
okay. We might get started then, and I'm sure a few people will pop in along the way
Yeah.
as well. Fantastic. Well, good afternoon, everybody, and welcome to the Irish Cancer Society Daffodil Research Webinar. My name is Sarah Ty, and I am the Cancer Survivorship Research Coordinator here at the Society. And it's fantastic to see so many of you here, numbers still going up, and also a huge amount registered. So we are recording today, which will be great for sharing afterwards for Martin and his team. So, as many of you know, our 2025 Daffodil Day is happening on Friday, the 28th of March, and we are inviting everybody to join us and go all in against cancer. And your involvement in Daffodil Day makes a real impact on the lives of people affected by cancer. So, all of the funding collected on that day and around the day, it contributes to the funding of groundbreaking research. It ensures that the qualified cancer nurses are available to those who need support, so especially our night nursing, and it maintains the free patient services that are available through the Irish Cancer Society. So it keeps all that going during the year. So we really encourage you to reach out into your communities on or before the 28th of March, and you can support Daffodil Day in your schools, communities, workplaces. You can host your own event with friends and family or in your community. You can even sell daffodil pins or volunteer to join us with book collections in the area, or join the actual team on the day out in Dublin. And there are some online opportunities, so you can have virtual collections. And really, there is something for everybody. So we'd be so grateful for your support. And today, in honour of our upcoming Daffodil Day, we have one of our incredible Irish Cancer Society funded researchers with us, Dr. Martin McMahon, who is an associate professor at Trinity College Dublin. And I think we all know and have experienced like socially excluded and marginalized groups facing specific challenges and real challenges in gaining timely access to cancer care. And this can lead to a multitude of problems then throughout their cancer care journey. So Martin and his team are currently doing excellent work exploring the unmet needs of cancer patients from underserved communities, as they're commonly known. And that is through the UCAN project. And personally, I think one of the best parts of the project really is the team's commitment to not just understanding more about how the communities access care, but really to identify proper actionable measures that can and will, Martin, if I have anything to do with it, be brought forward and implemented into the future. So it's just a quick reminder before we get started as well that the webinar is recorded today. And if you have any questions for Martin or his team, they'll be joining us at the end of the presentation. You can write them down in the Q&A box, and you should be able to see that down the bottom of your screen, and we'll get to all those questions at the end. So without further ado, I'll hand you over to Martin, and I can see your screen is already shared, and hopefully everybody can see that clearly. And yeah, I'll leave it with you.
Okay.
Thanks, Martin.
Thanks, Sarah, and thank you for the lovely introduction. And good afternoon to everybody here. And thank you for joining us. And thank you to the Irish Cancer Society for arranging this Daffodil Day research webinar. So I'm delighted to be here today alongside Dr. Louisa Lynch and Shauna Walsh, who've both contributed significantly to the UCAN research project. And we're also grateful to the Irish Cancer Society for funding our study and highlighting the importance of reaching out and undertaking research in underserved populations. I think this is reflected very much in the National Cancer Strategy, that there's a clear commitment to ensure that cancer awareness and prevention initiatives prioritise disadvantaged and hard to reach groups. So, as way of background, I suppose I'm a nurse by background, and I'm currently, as Sarah said, an associate professor. I'm head of discipline intellectual disability nursing at Trinity College Dublin, as well as the associate director of the Trinity Centre for Ageing and Intellectual Disability. And my work very much focuses on health inequalities and inequities experienced by people with intellectual disabilities and also other marginalised communities. So I look forward to sharing with you today how our study aims to deepen the understanding of how marginalisation and inequalities and inequities that underserved populations experience. And also, as Sarah said, to look at strategies that can improve access to cancer care for these populations. So over the next half an hour or so, the objectives are we're going to summarize the current advances and persisting gaps in cancer care for underserved groups. We're going to explore barriers to diagnosis, treatment, and survivorship. And we're going to report on and explore some preliminary findings from the UCAN study. And we're specifically today going to focus on some of the qualitative aspects of this study. And then, discuss practical strategies to enhance equity in cancer outcomes. You'll hear me talk a little bit today around inequalities and inequities. And this is something that very much drives the core of our research. So when we talk around equality, we're talking around things being the same. And typically, for underserved populations and hard to reach groups, typically things are not the same. But perhaps more worryingly is that they're not fair either. So even when things are the same, they may not be fair. And this gives rise to, I suppose, lots of difficulties in the area of healthcare more broadly. But when we consider cancer and it being such a time-sensitive issue around diagnosis and treatment, that's when these factors really come into play and cause, I suppose, lots of augmented or additional burdens for people from underserved populations. So if we set the scene, there's improvements in cancer care and survival, which is fantastic in the general population. We all know that regular screening is critical for early detection. And in Ireland, we've got our 3 national screening programs for cancer. Advancements in treatment options have decreased mortality, and there's better outcomes. So this is a very good news story, so it is. And these improvements are significant, but they're not evenly distributed across all communities. And people from underserved communities continue to have poor outcomes across the cancer care continuum in comparison to those who don't have, who aren't in a hard to reach or marginalized group. So when we think around marginalised groups, we now know that cancer is one, if not the leading cause of death in Ireland. And cancer risk factors, screening rates, stage at diagnosis, treatment, symptom management, and cancer mortality vary. And they vary by a person's age, their sex, their disability status, their health literacy, their socioeconomic position, their geographic location, and rurality. And when we consider marginalised and socially excluded groups, they face greater access challenges. And I've talked briefly there a moment ago regards to inequities. So what we're seeing that these inequities accumulate across the entire cancer care continuum. So for prevention, right through to screening, to diagnosis, symptom management, and survivorship. So this is why addressing the inequities is not just a single step, but it's very much a comprehensive and ongoing priority. And when we consider marginalized groups or socially excluded groups, so people who've got disabilities, intellectual disabilities, physical disability, maybe those from the traveling community or from the Roma community, these groups often face not just single barriers, but augmented and intersectional barriers. So, for example, transportation, stigma, awareness, the financial ability or capacity to be able to, to live maybe a more healthier life, or to be able to access health resources that the general population more broadly are able to exist. So we can start to see that it's a complex picture, so it is for people from marginalized groups. So when we talk around the potential mechanisms for cancer care inequities in underserved populations, and these may be directly related to an individual characteristic, such as things that they cannot change, such as age or disability, or also maybe other behavioral factors. But we also need to talk around the structural and institutional elements that exist. So how are healthcare organizations and how are policies established and executed within, I suppose, across the healthcare spectrum, and how do these impact people's access to diagnosis, treatment, and support? So this can lead, I suppose, to certain underserved groups facing poor outcomes, regards to being diagnosed with cancer, but also cancer treatment. So research exploring the specific barriers to these, what these individuals experience is imperative in order to improve timely access to diagnosis and also treatment and care. So I'm going to talk now in a moment about a study that we've been doing alongside the UCAN study. And as I said, my background is in the area of intellectual disability. But if we think around the cancer profile is very well documented in the general population more broadly, but not for people who've got an intellectual disability. So we undertook a literature review recently, a systematic review, because we wanted to identify, so in this underserved or marginalized population, how common is cancer and subtypes of cancer in this population? So concerningly, what we found is a high variability in the prevalence and incidence of cancer in this underserved population. We found that this population experiences a very high incidence of specific subtypes of cancer. So we're talking around colorectal and breast cancer in comparison to the general population. But what I suppose most concerningly that we started to find is that there was a concerning trend towards cancer mortality. So people from this underserved population, if they were diagnosed with cancer, they were more likely to be diagnosed at later stages, and they were also more likely to die from cancer. Within the literature, we also see issues regarding diagnostic challenges, such as this hidden majority phenomenon and diagnostic overshadowing. So they may seem complex words, but essentially what they relate to is that the majority of people who've got disabilities or intellectual disabilities are typically not known to services and are hidden. And when they do come into access with services, what we typically see is that their presenting complaint is overshadowed by maybe their disability or overshadowed by their cognitive ability or their ability to communicate. And this leads to the under-identification of cancer. And when cancer is picked up, it's typically picked up at late stage diagnoses. Also starting to see that some of the cancers in this population that are detectable by national screening programs, particularly colorectal cancer screening, that we said there was a higher incidence in this population. Starting to see that some of the colorectal cancers are being diagnosed below the age of the screening threshold that we would have in Ireland and internationally. We also see that for these populations, and this doesn't just relate to people with an intellectual disability, but more broadly to underserved populations, that there's poorer rates of cancer screening uptake, and often these factors are compounded by higher levels of multimorbidity, communication barriers, and these factors exacerbate the poor cancer outcomes that this population experience. And this, can be applied not just to this population, but I would imagine to other underserved and marginalized population. And what this, I suppose, goes to show is that there's a unique pattern of cancer in this population that potentially extends to other populations who would have the same issues. Another study that we were looking at alongside in regards to underserved population, while we're doing the UCAN study, was looking at access to diagnosis and treatment. So for people, again, with an intellectual disability, and we're looking at some of the key themes that started to emerge from the literature and how adults with an intellectual disability were experiencing the diagnosis and treatment. And what I can say is this was led by Dr. Louise Doyle, who we'll speak to at the end of this presentation. But what we started to see is that, a very concerning picture across the themes that we were finding. So what we seen that we were finding that cancer signs and symptoms, so as we said, the diagnostic overshadowing, were typically overlooked in adults with an intellectual disability, that their signs and symptoms were not recognized. And these were typically related to people being unable to communicate or self-report their symptoms. And then typically when people with then intellectual disabilities come into access with cancer services or with services, health services more broadly, that their attribution presentation is associated with their disability as opposed to being an underlying biological issue. And we start to see is that also in this population that screening, as I said, is uptake. Living circumstance was a really important factor. So because the elevated rates of late stage diagnosis, we found that if people lived in a group home or a medical facility, this was seen as a protective factor. But people who lived in rural locations or in institutionalized facilities, this was associated with less screening actually, and maybe that this is due to transportation issues or resources. And we will talk later about that with some of the findings that we found in the UCAN study. And then finally, what we found is that there was actually good outcomes. So there was for some people with an intellectual disability when their treatment was modified and tailored to their needs, particularly with what they were actually able to tolerate. And this was an important component in regards to access towards treatment and diagnosis. So there's some of the background work that we're doing in parallel to the UCAN study. But when we're going to talk now about the UCAN study over the next while, and the UCAN study, as Sarah introduced, is a study investigating the experience of cancer patients who have a physical or intellectual disability or those over the age of 65. So they were the targeted population who were defined as potentially being underserved. And this study was funded by the Irish Cancer Society just over a year ago, and we're just about to conclude with the findings now. And I'm going to present on 2 work packages today. So we had 5 work packages. The first 2 work packages are very much looking at the descriptive epidemiology of cancer, cancer types and subtypes in people who've got a physical disability, an intellectual disability, and those over the age of 65. And there was work package 1 and 2. Work package 3 and 4 then focused on focus group interviews, which were held with health professionals who had experience in the provision of cancer care for these 3 groups. And then what we did is in work package 4, we spoke to people from these groups. So these marginalized and hard to reach groups, so those over the age of 65, and those with a physical and those with an intellectual disability who had previously had a cancer diagnosis. And I suppose the emphasis is on that work package 1 and 2 was kind of like the quantitative evidence to describe it. But we really wanted to find out what were experiences were these populations going through. And I suppose one of the main findings which I need to draw upon here is that For underserved populations, recruitment is exceptionally difficult, and I'll explain that maybe in a bit more detail later. But to access people, not necessarily people over the age of 65, because they had a very different socio-demographic and maybe socioeconomic situation than those from other groups, but to access people with intellectual disabilities and those with physical disabilities was extraordinarily difficult. And what we typically found is that when we did identify them, that consistent with the literature that I'm after presenting around late stage diagnosis, their cancers are typically at late stage, and they weren't in a position to take part in our study. In one instance, we got ethical approval not just for the study from the Faculty of Health Sciences in Trinity College, but we went to different organizations. And by the time we had actually went through ethics, some of the people who had said that they would participate had actually sadly passed away. So that kind of really sits with regards to the late stage diagnosis that this population experienced. So when we take a look at work package 3, we used a gatekeeper approach to identify professional representative bodies and cancer support centres and daffodil centres, but also to try and reach out to different parts of the country. We used local radio stations and social media channels, and they were utilised for both work packages. So when we talk about work package 3, we spoke to 20 health professionals who had provided care for these populations. There was 4 focus groups and 5 one-to-one interviews. So typically what we started to see was obviously healthcare professionals were very busy and they didn't have time to maybe participate in focus group interviews, and we arranged one-to-one interviews, which worked quite well. For people with an intellectual disability, so we spoke to 5 people who had an intellectual disability and a cancer diagnosis, and we spoke to 6 people over the age of 65. And I suppose most concerningly, despite extensive recruitment campaigns involving, our steering group, which involved the Irish Wheelchair Association, Inclusion Ireland, and lots of other organisations, we only identified one person who was willing to speak to us who had a physical disability. So for work package 4 and 5, we used thematic analysis, and I'm going to present some of the results now. So the healthcare professionals that participated in the focus group interviews, we had a strong representation from radiation therapists, and this very much speaks to the challenges that radiation therapists have had with supporting people, particularly who'd got physical or intellectual disabilities. We've got nursing, pharmacist, occupational therapists, someone from academia previously provided support, general practitioners, dentists, and advanced nurse practitioners. So there was 20 health professionals in all. As I said, we had 4 focus group interviews and 5 one-to-one interviews. And then for work package 4, we spoke, as I said, to 6 people over the age of 65, 5 people with intellectual disability, and 1 person with a physical disability. And the intellectual disability and physical disability was analysed together. So if we take a look at, I suppose, they are 2 very different populations, particularly with regards to the people over the age of 65 who participated in the study were typically had a higher, should we say, socioeconomic status than the other populations for very explainable reasons. So we identified 4 main themes which were intersectional across work package 3 and work package 4, which I'm going to present on. So when we looked at communication, so what that very much focused on people who had limited communication and not the over 65 population. And communication as a theme was particularly relevant to the barriers that people with intellectual disability encounter when they had a cancer diagnosis. And the sub-themes in this, which I'm not going to present here, but they very much were around ensuring the patient understands the processes and reassuring the patient. When we talked around accessibility, we were talking around, that was very much around the ease in which patients can utilize health services, with a particular emphasis on how easy or difficult it was for patients with specific needs. Accessibility affected patients across each of the 3 cohorts, with the barriers mentioned by each of the participants who participated in the study. So in this theme, issues such as access to GPs, lack of money, physical disability accommodations, geography, transport, and accessibility were all sub-themes which form part of this. Personal support, and that was reported as being imperative across Work Package 3 and Work Package 4 in terms of enabling an individual from, a marginalized community to have a more positive experience during their cancer journey. And advocacy very much referred to supporting people here and taking actions to help them, and similarly to support them in ways which met their needs. And some of the issues around that we observed, or the themes we observed here, the sub-themes, were individual accommodations for the patient, support of family members, as I said, advocacy, support of a service, support of carers. Again, reassurance come up, and I suppose looking at then, excuse me, the difficulty support people in acute settings. And then I suppose the fourth theme, which was here, the main theme was systemic problems, and these were problems which affected the whole health system and affected all patients using it, not just underserved groups. And several systemic problems were highlighted by participants. And they typically, if we consider the sub-themes, they're around staff education, difference in staff knowledge, lack of community services, inaccessibility of healthcare, long waiting times, the hospital and community intersection or interface, and also this concept of a firefighting approach towards care and bed shortages. So if we take a look, I suppose, maybe at the first theme of communication, and which I said this didn't relate essentially to people over 65, but more people who've got intellectual disabilities, and the way in which patient, staff, and patient representatives exchange information. So communication was reported to be a barrier mainly for those who had an intellectual disabilities. And as we said, so some of the literature that I presented earlier on, often people with intellectual disabilities had difficulties verbalizing symptoms. They didn't, their cancer screening, reporting symptoms and symptom severity. So healthcare professionals were very clear that a difficulty of theirs was that people verbalizing symptoms and screening was very much to the fore. We thought it interesting when with regards to communication for those over the age of 65. You can see there, I think we've improved a lot in dealing with over 65. I would say that the majority of those over 65, we communicate with them the same as any other adult. And there was this view from health professionals that there was a shift away from the old year in inverted commas mentality. We take a look at some of the, I suppose importantly, people with an intellectual disability didn't report communication themselves per se, but health professionals cited this as a major issue. So we take a look at there, the challenges in our area with people with intellectual disabilities is sometimes they can't tell you that they're having symptoms. So it could be that someone recognizes there's something amiss and tries to find out. And then it can be a challenge to get somebody to hear that, or if somebody has, sometimes unfortunately, it's put down to somebody's behavior or somebody's behavior. And that very much feeds into this concept of diagnostic overshadowing. If we take a look here, one of the other focus group participants said, well, this needs to be communicated. And one of the biggest things that people talk about when up in the hospital in the acute setting is the communication gap. And that's what the acute setting needs support in. And they don't know how to say what we would like to say. And they don't want to feel patronizing, but they don't want to say too much. So there's a lot of unsureness. And that kind of fits in not just with maybe the situation, that healthcare professionals, but that fits in with, the international evidence regarding the difficulties in this area. We take a look at the second theme, then accessibility, the ease in which patients can utilize health services. So barriers identified included GP, accessibility, geographic location, lack of transport options, financial difficulties, and physical disability accommodations. So lack of transport came from Work Package 4 for people with an intellectual disability and a physical disability and those over the age of 65. So it was coming up across all work packages. So lack of people who were unable to drive often had had to rely on family, and that was seen as an issue. And charity services can help alleviate transport issues, but there was also, issues regarding it's not a complete solution because there are limited connection points. We found financial difficulties, so the ongoing costs of long-term side effects, the cost of travel and treatment, and funding necessary for additional supports. So attendance, so the financial burden essentially of having a cancer diagnosis. But this wasn't necessarily an issue with those over the age 65, where they reflected on typically, they have got the financial capacity to be able to do this, and how they cited that this might be an issue for other populations. Geographical location was very difficult. And when I interviewed somebody with an intellectual disability in the northern part of the country, they told me like a really difficult story about they had to get on a bus in a wheelchair for 3 hours to get to one location, to then get on another bus to go to another location for a couple of hours to receive radiotherapy. And this was a person who had an intellectual disability and had physical issues. And that was cited as a real barrier towards, I suppose, their cancer journey and cancer experience. If you had to do that for several days a week for a number of weeks. And that was one thing that really stuck out for me, is that geography and the geographic location for marginalized populations, particularly who've got additional physical needs, that was a real concerning issue. Some patients reported that they found their experience of cancer treatment particularly different due to location of the treatment of hospital, financial cost, and lack of provided transport. So also regards to physical disability, so we were told also that many GP surgeries and acute settings have equipment to accommodate disabilities, but this isn't always the case. So somebody who was a wheelchair user told us that they found that this was particularly difficult with regards to utilizing healthcare services. And also there was this we were told that most cancer diagnosis occurs through GP referral. Therefore, those without a GP, and if you're from a marginalised or hard to reach group, you're more likely to potentially not have a GP. Then they face a delayed diagnosis. And if we take a look at then the concept of like health literacy and the evidence that I presented earlier, you start to see a picture about these intersectional augmented issues, which you can see drive maybe poor access to treatment and poor outcomes for these populations. Yeah, it's a long journey, and especially because Mary, and that's obviously not a real name, a wheelchair user as well, it maybe not be the most comfortable journey as well. A focus group participant told us that I did mention the mammograms, difficult to access mammograms, but even on a really fundamentally basic level, it's hard for GPs to examine some patients who have come in a wheelchair, for example, and aren't able to do or to need a hoist or a transfer. Like, I don't know of many GPs who got a hoist on site and they can examine someone. So if we start to think around the UNCRP and the rights of people with intellectual rights of people with disabilities, we can start to see that significant issues arise. I think that can be a big problem. Then I think getting a GP is an issue. There is a shortage of GPs, so I think that can be a problem. And it's the patients who shout the loudest who get the GPs. And this came from a health professional. And very much here, if we take a look then about someone over the age of 65, I just sitting there every day for 6 weeks on a bus, it killed me. My back was very, very sore. Yeah, I was in agony. And when you consider that's from someone who was over the age of 65, who didn't have a physical disability, if you consider geographical location for somebody who's explained in the wheelchair, you can start to see the issues for people who are traveling on buses, and then we start to see the issues there. So we said then the other team regarding personal support, which to reorientate, that looks like the sub teams were individual accommodation, support of family members, have an advocate, personal support of a service, support of a care, reassurance patients, and in acute settings. So advocacy and empowerment were important to professional and also to the patients, so the people who participate in the study. So some Patients felt that having longer appointment slots would help them feel more comfortable during treatment. And this was very much to the fore, was that the support of other people, so family members particularly, can notice cancer symptoms in someone with a severe to profound disability, and GPs can depend on them to relay the symptoms. So it's very much about people who don't have a voice, about which other people can support them. All participants then mentioned three groups of people who supported them in their cancer journey, and these were seen as critically important. So participants mentioned, their family, their service staff, if they were accessing the service, and their friends. And if we take a look at some of the things that we were told under this team, it was great coming home here after and just talk to Mary, the key worker, and nobody else. So this was somebody who was having treatment, who had an intellectual disability, but it was time that when they got home, they got time to debrief, and they got time just to be on their own to talk to their key worker about what they'd went through. And then we were talking around one of the this is coming from a radiation therapist, and it was very much around having the person's advocate there to support them, to be able to tell them actually about this person will only tolerate X, Y, or Z, or 10 minutes treatment, or if they can't manage it. So it was very much then the health professionals telling us that people have got supportive measures along with them. Yeah, one of my sons was a great support now. Yeah, he was. He stayed with me when I had chemo and everything. So that's like the family support there for somebody over the age of 65. And then another one was that someone who had a physical disability. I was lucky in that I had like good family and good friends that I could just talk to. I think that probably powered me through. And we consider that if we consider people who come from marginalized populations, they're less likely to have, maybe close-knit networks, or they're more likely to experience isolation. We can start to see then, regards to this absence of personal support, how this may impact their cancer journey. The other theme then around systemic issues, and that was problems which affect the health system as a whole and affecting all patients using it. And if we talk around, this was around staff education, difference in staff knowledge, lack of community services, inaccessibility, longer waiting times. Several systemic problems were highlighted by participants as issues for patients with cancer from marginalised communities, such as inadequate public health messaging and a lack of community services. And those within this cohort were more at risk of facing systemic barriers than those in the general population. For over 65s, there was a lack of community support services available, we were told, preventing people from moving from hospital to living at home with support and affecting their quality of life after cancer. Some of the issues that we were told here was from one of the professional interview participants about written resources. But written resources are not the way. Like, those lovely big leaflets, the pamphlets, booklets are written out, but they're very intimidating, even to someone who speaks English natively. Like, if you are not confident in your literacy, and even if they're in plain English, if it's just a booklet with multiple pages, I just don't think it works. Uh, and also, one of the focus group participants told us we still continue to do the firefighting because the capacity overstretches, the demand overstretches the capacity. And if you can kind of consider that, and then you consider that people from marginalized groups are less likely to have the capacity to be able to maybe shout the loudest, as we heard previously, and then there's this firefighting going on. We can start to see then why these challenges are more augmented and are more maybe a more detrimental impact for this population. So that's just a quick overview. I'm just watching time here at the moment, but the application of these findings. So what do they mean with regards to the application of what we've been told? So we consider one of the key things is the reasonable adjustments in communication, which is quite clear. We talk around many professionals reported adjustments they had made in their work and offered other solutions as to what may accommodate other patients. So professionals saw the importance of working with patients on a case-by-case basis and being flexible to the individual patient's requirements. And this is, all very good and well. But when we consider one of the previous points there regards to firefighting, you can see how this may be negated or not responded to. But I think it's very powerful, that this is coming from health professionals saying about how important that it is. Radiation therapists reported that desensitization can be very important for patients when preparing for radiation therapy, and that's something that is very actionable, that can be potentially developed and be developed further. Also, health professionals told us that patients have benefited from having tour of hospital rooms and where they'd be shown where they're getting their blood taken and what things like that are like. So very much around these reasonable adjustments that may make things better for people from these populations who are being diagnosed, who have had a cancer diagnosis. Uh, Helping to make people make their own bespoke plan each time, recognizing that everybody's working together to figure it out, as opposed to there's no one size that fits all, kind of really helped in the end. And some of the radiation therapists, and I think this is a really fabulous idea. It's like so simple. Bought stickers and made up a sticker card with 28 little windows on it, and every day then she came out of the room and she put a sticker on the cards. That was for every day she had treatments. She could see that there was an end in sight. I think that's just something so simple and so visually important. Um, yeah, we've done a lot of easy read and audio tapes, and Mary is blind, and a lot of audio tapes and stuff. Yeah, we got to try, to explain about the cancer. And that was someone who had an intellectual disability, and that was about how there was reasonable adjustments being made to respond to her communication needs. And then I suppose from our perspective, the important thing is that we kind of treat them as an individual and look at their individual needs, and rather than have an umbrella kind of approach. So it's very much people are very cognizant, and professionals are very cognizant and aware of having this person-centered approach towards people's needs. So both patients and professionals report ways in which communication could be improved in the acute setting. Communication tools and providing more resources we're seeing as important to support professionals to share the correct information. And this was professionals being very open with us, saying that they need support in order to be able to communicate effectively with these populations. And it was very clear with regards to this concept of person-centered communication, and that they're communicating with the person and respecting and valuing their unique needs. So I suppose that's a quick overview of some of the findings and some of the work that we're at that directly relates to underserved populations. But what's next? And I suppose when we consider what's next, we need to establish a program to target marginalized cancer group and people from marginalized groups. There's some quick wins, so we can create very much easy read materials that can be used across the cancer space for regarding treatment. I think we need to have recognizing what is in the UNCRPD and things being universal by design, so that ensuring that what we create doesn't just meet the needs of one marginalized group, that meets the needs of many marginalized groups. I think there needs to be a greater emphasis on developing of DVDs and YouTube videos to help illustrate what happens with different diagnostic tests and treatments in order to support people from these marginalized groups. And there needs to be, I suppose, a real focus on accessible practices and centres across the country. And we can explore them further. And health professionals have told us and very clearly that they need support to help them do their job better and to meet the needs for cancer care needs of marginalized groups. And I think we're at the stage now where there's a new cancer strategy, will be coming in in the not too distant future. I think we really need an action plan with accountable actions for targeting hard to reach groups for people, from these populations. Because if we take a look at some of the evidence I presented earlier on from some of the work that we're doing and some colleagues internationally, we take a look at some of the findings that we are seeing here. And I didn't present on work package 1 and work package 2 because it's very numbery. But what we are seeing, particularly for people with an intellectual disability, is that they experience late stage diagnoses, and sometimes they don't have any cancer diagnosis, but then when it's been reported that they're actually dying from cancer when we explored their death certificates. So there is some critical inequities and inequalities that exist in this population, and I think we need a targeted approach and response to address these issues. So just quickly to again thank the Irish Cancer Society for funding this study, and also to the research team who were part of this research study. And just to say that we have got a conference in the next couple of weeks that the Irish Cancer Society are going to also be presenting at. So I'm going to stop sharing my slides now, and I'd be delighted to take any questions along with Louise and Shauna that you may have.
Fantastic. Thank you so much, Martin. So I think before I even move on, I'll just introduce Louise and Shauna. So they are both working on the UCAN project with Martin. And I thought it would be remiss not to bring them into the conversation at the end, seeing as they have such an important part to play. And I don't think, Martin, you could do it without them. They're a fantastic team. So actually, Miriam, I see you have your hand raised. So I'm not 100% sure if you're able to turn on your mic because it's a webinar, but if you'd like to try. No, I don't think so. Miriam, just because it's a webinar, usually the attendees aren't able to do that. So if you wanted to pop your question into the Q&A in the bottom, I, of course, will jump straight through it. So yeah, Martin, I just want to say that was just a wonderful talk. And I think for me, just some take-home messages that I like personally was really about the insights into the diversity of barriers. And I think that's something that I didn't really think of, because when you're looking at these underserved communities, it's like, oh, well, what can we do? We can help access here, do X, Y, and Z. But really, it's very, very diverse. So, I mean, I think we can't do everything at once, but really some creative thinking is needed to ensure that we're really identifying those gaps, and then really striving for true equity. And I think that's really highlighted through the UCAN work, because like I think at the moment we seem to be settling for a kind of equal access to services, but really I think the take home message would be there that the supports are needed in conjunction with the services then to really improve that equity. And yeah, I just think it's really important work that you're doing, and we've tons of questions in, so I will go straight to them. But I think two questions that kind of merge into one, and I think it is an important one, is about really definitions and how we are identifying these groups, or even what they're called. So there's a question about developing the definition for marginalized groups, and is there any PPI involved in that? And then there was also another one about what constitutes an intellectual disability in this study? So really, like, how did you kind of classify what cohort you're looking at?
Okay. Yeah, so the definition of the marginalized group, so that was very much from the Irish Cancer Society regards to the definition of underserved groups, and they were the three populations essentially. What was defined. Was there PPI involved? Yes. So we had PPI. So all our work is very much PPI is included from inception right through to undertaking the research to dissemination. So we've had lots of people from these populations inform us about the research questions initially, and also as throughout the study, as Sarah will know because she's been part of the steering group, we've had advocacy organizations that represent each of these three populations that guide, to give us feedback, that tell us when we're not doing things right, that tell us, that really give us really strong grounding in the real world, issues. So yes, that is very much that's how PPI was involved throughout the study, and also that's how the underserved or marginalized groups were there. Regards to a definition in intellectual disability, sorry, that's probably something that I may should have said at the start. So when we consider typically an intellectual disability as somebody who would have deficits with adaptive and social functioning. What I mean by that is they've got deficits in everyday life skills and have got a reduced ability to learn new or complex new skills that occurs during the developmental period, so before the age of 18. And if you were gone into a very medicalized view, you would typically see they would have an IQ below 70, essentially. So that's what an intellectual disability is, and represents about 1 to 3% of the population in the developed countries.
Fantastic. And yeah, Miriam found the Q&A box. Hi, Miriam. So just saying that it's a fantastic presentation, but also wondering about health professionals and having training. So, is it training pre-qualification or is it really a learning on the job situation?
Yeah, I might take that and then I'll let Louise and Sean because they've done so much of this work. So there's no
Yeah.
point me, so I'm going to hand it over. But that Miriam, I think that's a brilliant question. Okay, what we have if we take a look at health professional curriculum uh, internationally, they typically have very little core curriculum content in the areas of marginalized populations, and that's highlighted in the international evidence. So it should be, yes, by exposure towards, throughout their training, but also coming more in contact with people from marginalized groups. So historically, what we would have seen, particularly people with, disabilities and stuff like that, is that there is a belief that people with disabilities are looked after by disability services. So there's a fragmentation of who provides care for certain populations. So I think that's important. And that's not the way, we've got a universal healthcare system. So it needs to be universal access. So I think that's really important. So yeah.
Louise and Shauna, did you want to say anything about that or we move on to the next?
I think as well, Ireland is very unique in that we specifically train nurses, and sorry for the focus on intellectual disability, but we have nurses specifically trained in intellectual disability who can act as liaisons, but unfortunately, we don't have enough of them. Which is a problem. But if we had more of those, and if there was a few in each location and spread around the country, that would
Mm,
help all of these marginalized communities, I think.
yeah.
Fantastic. And I think as well, there were other questions as well about national policy. So, are there any national policies in place to ensure that there are going to be reasonable adjustments, that are supported across the hospitals, or is that something that you're going to have to kind of embark on, once this kind of body of work is finished up?
Yeah, well, there should be like it should be reasonable adjustments by design, essentially. But when we take a look at, we've looked at different populations in this study, people with a physical disability, people with intellectual disability, and those over the age of 65, uh, and why, there are policies. If we take a look at UNCRPD, for example, so people who've got disabilities, then that's a treaty. There's certain requirements that, organizations should adhere to. So there is, but not necessarily explicit, essentially, that says you should do X, Y, and Z. And I think that's towards we need to move to a situation where we've got access and inclusion in the inception and design of health of health services. So screening is one perfect example. So these populations typically have lower access to screening. So we take a look at what is a very explainable reason for that. Well, the first thing is health literacy. So about access and about understanding people getting opting in and opting out and stuff like that. So there's this real easy explainable answers for some of them issues. So it has to be inclusion and access needs to be inherent in the inception design of services to try and meet everybody's needs. That's my own personal view.
Mm. Yeah, and I think as well it's such a wide group because I think like Amanda McCann from UCD and Elaine, you probably know them from the patient voice and cancer
Mm,
research as well. And they were just saying like we have ethnic minority communities who also have disability issues and that intersectionality. I mean,
yeah,
where do you even start with that when you're thinking about bringing in, legislation or policies? It's like it's such a wide ranging. So even having something at the core
yeah.
to
The
kind of make sure it's
intersectionality.
considered.
Yeah. So if you
Hmm.
take a look at somebody over the age of 65 who's got a physical disability, so you've got, and that's what Amanda is talking on there. So someone over the age 65 who's got a physical disability, who's also from an ethnic minority. So you've
Yeah.
got the augmented intersectionality, which will add increased, burden to this person's journey. So
Mm.
maybe Shauna, because Shauna has spoke to lots of the healthcare professionals, and
Yeah.
which what we found really interesting was is that the healthcare professionals they know the solutions to these answers. Like it's not like there's groundbreaking novel findings that they told us. They told us what the solutions were.
I think even from speaking to the healthcare professionals, even though it was quite, we identified a lot of barriers that Martin went through. I think the kind of take-home message from that work package as a whole was quite positive because a lot of the healthcare professionals could actually identify the solutions, and they really cared a lot about kind of the issues and like minority groups. Kind of the issue was they don't know how to implement the solutions. They can think if that's not their job. It's it's a higher level job that is like.
Yeah, it's not easy. And I don't mean to throw another spanner in the works, but also another question that came in, I think it's a very relevant one, is giving the scope of the types of communities that you're talking about, do you think research studies like this or future research studies are going to be important given the current global political climate? And obviously how that's changing the scope of I suppose the definition of these marginalized communities.
Yeah, I'm going to take that. So I've seen that question come in. I think it's really interesting. But I
Mm,
have to say, we're really lucky in Ireland. So if we take a look at since the new government have actually come into power, one of their key issues is actually disability. So that's people who've got neurodiversity or people who've got physical disabilities, intellectual disability, lots of, in disability in a broad sense. And that's been a real key focus for the government. So I think yes, it will be. And I think if it in very early in this government, we've heard a lot about like disability in the news. We've heard a lot about how it's now plans to bring it in under the Department of the Office of An Taoiseach. So if we take a look there, I think that's really heartening to say is that yes, there is lots of global turmoil. But I think from an Irish perspective, I think that with regards to marginalized or potentially vulnerable populations, is that there's a recognition from policy, from governmental policy, that these people have got needs and they're trying to address that at a very early stage. So I think that's really positive. So I think that
mm,
kind of speaks very much to that.
great. Yeah. And I suppose then just moving on then from your, thoughts on international versus, national, there are some questions about the kind of geographical representation of the study that you did. So one was regarding the systematic review, and were the papers that you were looking at there really describing the Irish context, or were there international differences between our context and that, and then also just about the geographical representation of the healthcare professionals that were interviewed as well.
Okay. I'll take the systematic review and Shauna can talk to the healthcare professionals. But the systematic review is very interesting because, like how we found it really difficult to identify people who have intellectual disabilities and so on and so forth, internationally, it's really difficult. So there is only like a handful of studies where you can identify people who've got an intellectual disabilities in large enough studies which can actually, determine. And they have come from Scotland, Canada, and the Netherlands typically are three of the largest studies. And that's where they're able to identify people in large scale studies. So, for example, the largest study that I know of was in Scotland and in Canada. In Scotland, they now have in the census, which we also do in the census in Ireland, they have a variable where you can identify intellectual disability. But what they have in Scotland that we don't have here yet is the ability from like the CSO to be able to link that data with cancer registries, and they've done that in Scotland. So that's so we've had no Irish study. One of them studies was actually mine, but I did it in the UK. So we've no Irish study essentially in that review. And Shauna can speak to the health professionals, the geography.
Yes, so I suppose because we used a gatekeeper approach and recruitment was self-selecting for work package 3, we weren't sure about the geographical representation that would kind of come about. But we were very lucky that we actually had quite an even spread of staff that were actually from acute and community settings. So not only did we have a good geographical spread, but we had a good kind of spread of where the staff were working as well. So we got a lot of different perspectives, which was really beneficial, I think, in terms of the analysis.
Yeah,
Yeah.
that's fantastic. And I'm so sorry, but I'm just looking at the time and we are going to have to wrap it up. But like I think we could probably sit here and unpack this for the next hour. And there were some other questions. So I will kind of forward these on to the team. Again, a lot of them are anonymous, so I'm not sure where to send those
Yeah.
answers to, but it may just be food for thought for the team moving forward to the next stages of the project. But just
Sarah, can I
yeah,
add one question I
yes.
really want to answer, and it's
Yeah.
the Irish Cancer Society works really
Oh,
hard in terms of advocating for more equitable, improved cancer care. Absolutely. And what I
yeah.
think it has to be recognised is that this was like one of the first funding calls in Ireland, which has,
Mm,
and the Irish Cancer Society are a charity essentially, and this is one of the first funding calls which seeks to address, underserved populations. So I think that is amazing. So I think it's our job now to give you results which are actionable, which
mm,
can be used to lobby for change. And I think what can the Irish Cancer Society do? I think it's continue doing what they're doing and to use these
yeah.
results to lobby and to advocate for the needs. So I think that's the next point. But just to recognize that, this has been the first funded study in this kind of stream essentially for original research. So yeah.
Yeah, oh, it's amazing, and we're very, very proud of that. And it's great to see, like you said, actionable work coming
Yeah.
from that funding. And I think as well, even with the transport services that we have and the financial advice services and the different grants that can be applied for, it's just maybe just keep going with that, I suppose, is probably a good way
Yeah.
to start, isn't it?
Okay.
But yeah, thank you so much. That was just a really wonderful presentation. But my favorite thing about webinars is when there's a really interesting discussion afterwards. So I'm so glad that Shauna and Louise, you came on as well. And thank you so much for giving people all of that insight. And again, just a quick reminder, just a last plug before we leave, to go all in against cancer on the 28th of March by getting involved or donating to Daffodil Day. And I popped a little image into the chat there that has a QR code. So if anyone needs any
Thank you.
extra information, you can find it on www.cancer.ie. And I will share a recording of this webinar for anyone who was unable to attend. And yeah, thank you so much. And we
Thank
hope
you.
to see you again soon at another webinar. Chat
Thank you.
soon.
Thanks,
Bye
Sarah.
bye.
Thanks. Bye bye.